Hello, esteemed Beyond Telemedicine guests, and welcome back to our second session on day 2 of the program. My name is Dr. David Harrison. I'm the Vice President of Clinical Care at Virta Health and also a primary care physician at Massachusetts General Hospital. Our next topic centers around reimbursement and payment for virtual care services. We are writing history as we speak and reshaping the way healthcare is delivered in the United States and across the globe. To help understand this, during this panel, you'll learn more about the rise of value-based care in the age of telemedicine, the promise of ACOs and bundled care models, the future of payments for telehealth visits, and we'll close with an awesome case study on how North Carolina's Medicaid program built its telehealth program from the ground up in fewer than 2 months after the pandemic hit. To discuss these important and exciting issues, we're bringing in a panel of great speakers. Sean Cavanaugh, former Deputy Administrator of CMS and currently the Chief Administrative Officer at Aledade. Dan Schellenbarger, Partner, Oliver Wyman. Dr. Mark Smith, Founding President and former CEO of California Healthcare Foundation. And Dr. Shannon Dowler, Chief Medical Officer, North Carolina Medicaid. Strap yourselves in because this will be an exciting ride. Hope you enjoy. The shift to value-based care in the era of telemedicine. What is the relationship today between value-based care and telemedicine?
So as you know, for the last several years, at least the last decade, we've been moving more and more towards a system in which we want to pay providers, both as individuals and as organizations, not so much for the effort that they put out or the number of times that they interact with a patient, but rather for their results. And this is broadly called value-based care. It has different meanings in different contexts, and there are different ways that it can happen. But broadly speaking, the notion of fee for service, I do this, I get paid for doing this, as opposed to what the doing this produces in terms of your health or wellness or well-being, I think is a broad trend that will be accelerated by COVID for really 3 reasons. The first is that everybody who was being paid for fee-for-service saw their business model go all to hell immediately because visits dropped through the floor. And so if you're getting paid by the visit and visits drop through the floor, you're not getting paid. That's part of why a number of practices, particularly primary care practices, are really in serious trouble now, and we may see them fold. And they have been sustained only in large part by government assistance that would have been really unthinkable a year ago. The second reason that value-based payment has been accelerated is that patients have gotten a taste of value-based care in that they've been able to interact with their physicians in a way that is really different from the way they had before, and for the most part, they like it. So for the millions of Americans who've had their first experience of virtual care because they couldn't go in to see their doctor, they now realize, as some of us have realized for a long time, that there's an awful lot of stuff that we've been doing in person that need not be done in person, that is far more convenient and far more accessible to patients if it's done through modern IT in the way that we now do most every other service industry virtually first through modern IT. Then the third thing is that I think for physicians who've been tied to kind of the hamster wheel of fee for service, they themselves have recognized that they can have a more efficient practice. They can have their office open not 5 hours, 5 days a week, 8 hours a day, if that's not how much they need to see people in person, but they could adjust their schedule, their work life to optimize the way in which they take care of patients if only they could be paid on a different basis. And so I think for patients, for organizations, and for physicians, they've been forcibly awakened to the fact that there was an awful lot of wasted time, wasted motion, wasted effort, wasted money in our old system that was tied to the way we paid people. And to the extent that we can evolve the way we pay people, it will unleash the capacity of modern IT to provide more convenient and more accessible and more efficient care in the way that it's revolutionized every other service industry around us for the last 20 years.
I think the future of payment reform is directly tied to the future of telehealth. for the reasons I said before, which is payers, whether it's Medicare or Blue Cross plan, are going to be much freer in allowing the use of telehealth if they have the sense that the people using telehealth have an eye toward value, better care at lower cost. So I think, I was at the Innovation Center as early as 2011, and I think all of us were much more hopeful about the transition of value-based care at that time, and we haven't quite made the progress we had all hoped. But I still think everybody does realize that this is inexorable. We're not going to go backwards on this. We may be moving too slowly to value, but we're moving toward value. And telehealth could be a spark to help propel value-based payment and vice versa. As clinicians, but also patients, feel drawn and more comfortable with telehealth, as they push for this to be accepted, payers may be pushing more models that allow for that. So let me give you one example. One of the things about telehealth, like I said, is none of us want it to be an engine for fee-for-service medicine. But what if primary care capitation became a bigger part of our payment landscape? What if payers said, listen, we don't want to be deciding what methodologies you use to take care of your patient. We just want to pay a predictable amount per patient. If we see more and more primary care capitation, then you can see greater uptake of telehealth and other creative ways of caring for patients. So I do see there's a relationship between these two of the future of technology and the future of telehealth is tied to the future of value-based payment and possibly vice versa.
How is value-based care currently being practiced in the US? Are there ways we can accelerate that adoption?
The adoption of value-based care and value-based payment today is very mixed. I'll start with, at Aledade, all of our physicians are in value-based care models, some of them just for Medicare, but we try to fill out their patient panel. If you're creating new workflows and new data flows for a set of your patients, you really want to do it for all of your patients. And we at Aledade try to meet that need for our physicians. We certainly see, though, what we call squatters. These are people who've joined, whether it's a health system or some other amalgamation of providers, who join accountable care organizations more as a defensive strategy or an exploratory strategy. It's not a wholesale commitment to a new financial and clinical model. So I think we're really still very much in a middle ground where we don't see a lot of providers that have wholly converted to value-based payment. And I do think that's a threat. As long as people have a foot in both camps, there will be the allure of the easy money on the fee-for-service side. So one of the things I think is, I've long thought, the success of the value-based movement will partly be dependent on whether we can accelerate the movement to value. The pace of change, we need to show that it's not reversible, but also that people that make a commitment, make the investments to practicing a different way, that there will be a viable business model in that direction.
The promise of ACOs and bundled care models. While at CMS, what payment and delivery models did you test under the umbrella of value-based care? What was the outcome?
I think when I was early at the Innovation Center and, part of a large group of people who were trying to foresee the future of value-based payment, a lot of the models fell under the general rubric of accountable care organizations, and a lot of models fell under sort of episodic case-based payment or bundled payments. And to me at the time, looking into the future, I thought, well, the bundled payments are sort of a slam dunk. If we price them right, those will generate cost savings right away. The accountable care organizations is much of a less proven concept and more speculative, and I had my doubts about it. And the irony is the truth has turned out to be just the opposite. The models that have consistently been documented to show savings for Medicare are the accountable care organizations, and specifically physician-led accountable care organizations. And this is not just Medicare, we've seen it repeated in the private sector as well. Many people have focused on that ACOs haven't saved Medicare as much money as many of us had hoped, and that's quite true. But they need to understand they have saved Medicare money, and they are a very large experiment. And I think there's potential to do much better. The bundled payment models, unfortunately, have had a much more mixed result. I think some of that is due to selection effects, where when you set a price, participants who think that they are already below that price get into the model, and those who are higher cost don't. So I think we might need to move toward more mandatory models. But that's been the most interesting development, is the success of the ACO models versus the bundle models so far. But I think there's so much more to be done and so much more to learn that I wouldn't draw any conclusions too quickly on that.
Now that you're at Aledade, how do you see ACOs using telehealth to improve patient care while lowering costs?
Yeah, ACOs and vendors, it's a very interesting phenomenon. I think you need to really think of telehealth as there's really two types of telehealth. One is the type that our practices at Aledade practice, and that is a physician in a rural or suburban community who's just trying to maintain contact with a patient that they've had a relationship with for many years. So as you know, most Medicare patients have multiple chronic diseases. So their primary care physician is dealing with them on a longitudinal basis, trying to maintain a relationship, manage their medications. So for them, telehealth is just another tool for not losing touch with that patient. In another population, when you start talking about vendors, it's much harder for a patient to have a longitudinal relationship with a specific physician who will manage their care over time if it's through a telehealth vendor. I think the telehealth vendors are going to be much more successful at providing episodic, urgent care, convenience care, which may be a different population than the Medicare population, which needs, as I said, help with multiple chronic diseases. So ACOs in the Medicare population, I think you'll see some mixed to neutral feelings about using vendors and more thinking of telehealth as a tool that the providers can use to stay in touch with their patients. As you spread to more commercial populations or younger working populations, then you'll see payers and maybe employers thinking of this is a good benefit to have as a convenience and more episodic or urgent care solution.
Reimbursement for telehealth services during the COVID-19 pandemic. How will the updated reimbursement rules resulting from COVID-19 affect the future of payment for telehealth services?
It's a big topic. So the short form, of course, is that when the pandemic set in, CMS put in waivers to say we're gonna pay for telehealth and telemedicine in ways that we haven't in the past, and they expanded the amount of services that were covered. And private insurers were then quick to follow suit, saying, "Hey, this is the time we need to go do this. This is a better way for our members to get care." And so the reimbursement establishment, if you will, kind of took the restraints off of reimbursement, and so that allowed a lot of providers to then say, "Yeah, I can do this because I will also get paid for it." And this is a very important thing as electives were shutting down and visits were becoming harder to come by. So that's the history. The big question, of course, now is where does it go from here? And this debate is far from settled. I think the extent to which the restraints were released, I think will come back, right? That will not live in an unconstrained world. However, even as of I think yesterday, MedPAC started its discussion and discernment process around how do we think about this, and how should we motivate and incent and reward telehealth as a modality. And I think you'll start to see an interesting coalescing of telehealth reimbursement and or some way of paying for it to allow that capability to exist within a practice. But I think you'll see that connected to value-based payment, right? So if I'm willing to bear risk as a provider and care for care for a population and ensure that their outcomes are at a high level, then telehealth absolutely should be a part of that, and there should be no real concern that I would be abusing that as a provider. I'm not going to use it to amp up my revenue for revenue's sake, but I would use it as a means of engaging and supporting my population to better outcomes. And so my hope is that despite having unconstrained it in the pandemic, that we'll not over constrain it as we come out of the pandemic or we live into the future here, but that we'll rest at a point that says, no, this is absolutely a very valuable part of our mix and very valuable part of what we need to be offering to care for our communities.
Case study, the rapid launch of North Carolina Medicaid's telehealth program amid COVID-19.
So my name's Shannon Dowler. I'm the Chief Medical Officer for North Carolina Medicaid. North Carolina is an interesting state where Medicaid is concerned. We have a large number of beneficiaries, 2.2 million. We expect to be up to 2.4 million in the next fiscal year because of the effects of the pandemic. We are a non-expansion state, so we are one of the few states remaining who has not expanded Medicaid. And we're a non-managed care state. We are scheduled in July of 2021 to transform to manage Medicaid. But right now we're in a fee-for-service, non-expansion Medicaid program. So telehealth in North Carolina before the pandemic was extremely limited. We were fairly far behind the curve of states for expanding telehealth for the Medicaid beneficiary program. In fact, we only had one telehealth policy. It was a consultative only policy, essentially where a patient would be in a practice and then would get zoomed into a specialty office, and the specialist could then bill for the telehealth visit. We had started a body of work on modernizing telehealth back in December, and recognized that it would probably take us 3 years to get it done and to find the fiscal authority and to get the legislative authority to do all the telehealth change we wanted. And instead we got a pandemic and we did it all in 7 weeks. And I would say we did it all and even some more. So over the course of the 7-week period in March and April, we actually enacted a total of 367 flexibilities in our Medicaid program. Of those, 135 were telehealth flexibilities that impacted 482 billing codes. And now we're looking at keeping at least a fourth of those as permanent changes, and we're continuing to evaluate for others. So essentially, we had a weekly cadence where we would do the high priority modifications first to our telehealth policy, turning on telephonic, turning on portal communications, making it a non-consultative model. And then we went into some innovative areas where we created some new types of visits. And then lastly, when we saw that the pandemic was going to be with us for a while, we went into the preventive care as our last step. At the same time this was all happening, we were recognizing the need to adjust provider rates. So simultaneously with the telehealth changes, we were focusing on how to support providers in the state. We started with our safety net providers first, then we moved to long-term care and hospitals, and then did broad rate changes across the board as the next wave. So one of the innovative models that we developed that I'm particularly proud of is we're calling the hybrid visit. It's a home health telehealth visit. And what that does is it allows a practice to do a home health visit without the provider being out of the office. It's not cost effective for a practice to do home health visits as a rule. I used to love doing them when I was clinically active because you learn so much about a patient and their environment, but it just wasn't practical. So with this, you could have a staff member, a trusted staff member, go into the home, coordinate and facilitate the telehealth visit, but also do other things, collect vital signs, do focused exams, maybe look at diabetic foot, any additional testing, spirometry, or a pregnant woman might need an NST. You could do labs, immunizations, medication administration, and the provider gets that enhanced home visit rate with the benefit of not having to leave the office. And so it improves, allows them to still be clinically productive, and we don't reduce access to care. The other innovative code we took was the physician-to-physician consultation code. That was something we had not turned on in North Carolina. It existed historically for primary care to specialists, but one of the ways we changed it was to allow it to be used between advanced practitioner and primary care. And the idea of that was to expand supervision and collaboration of advanced practitioners. North Carolina is not an independent practice state, so there's always a collaborative agreement, but oftentimes advanced practitioners will be reluctant to call their supervising physician because they don't want to bother them. They know they've got a full panel of patients too. And so it works for everyone that there's some way to collect work RVUs and show that the work you're doing actually has value. This also, of course, expands expertise in the specialty world. And if you're in a rural community or you have transportation difficulties or in the setting of a pandemic where you are chronically ill and don't want to go out, it allows a primary care physician who might feel like they've maxed out everything on maybe a complicated diabetics care to do a consultative visit with a specialist offline from the patient. And that specialist then gets paid for the work that they're doing. So we thought those both were some innovations that we turned on during the pandemic that were meaningful. One of the other things our ACE quality team did during the pandemic was we looked at where telehealth was actually happening, and we created a map of the telehealth deserts where different practices just weren't doing any telehealth at all. And then we got outreach, practice support outreach through our contracts with AHEC and an organization called CC&C in the state. And those practice supports would go into those practices that weren't doing telehealth and see how they could help bolster it, and to teach them how to use it, how to create the billing codes, how to help them find the technology if they were having difficulties. When we look at what happened with claims as a result of the pandemic, you see this huge drop. We always see a seasonal drop around Christmas. You see that short 2-week spike, that's Christmas and New Year's. But what you saw with the pandemic was a 9-week drop that really persisted. And at the same time as those face-to-face claims were dropping rapidly, we were turning on our telehealth and telephonic codes, and you could see those climb. We looked at how behavioral health was also using these codes, and it was very much in line with the medical physical side of things, where they were seeing significant increases in utilization over time. Our behavioral health world is under managed care in North Carolina, and did not have a lot of telehealth modalities approved before this time. And so much like our primary care who weren't able to use it, our behavioral health had not been using it. So the teams had to work really quickly to build this capacity in North Carolina to increase the uptake. So we asked ourselves, are we just getting the same 100 beneficiaries over and over again using telehealth, or are we actually reaching out to a wide variety? And in fact, we've got about 20% of the Medicaid population by June had been engaged in telehealth. Those are unduplicated patients. I imagine by the time we get to our August claims adjudication period, we will find that it's a significant, maybe even majority of beneficiaries utilize telehealth in one way or the other. And going from a state that didn't have any telehealth for our Medicaid, essentially, other than the rare consultative visit, largely with a psychiatrist, this was a pretty significant utilization. One of the other things we looked at was whether we were seeing primary care utilization. And what we saw was that there were a handful, 91 practices, that did the vast majority of the telehealth visits. Almost a third of their panels were actually getting reached. So much more likely to close care gaps in those practices that were high utilizers of telehealth during the pandemic. We also looked at whether patients had a hospitalization following a primary care visit with different modalities, in-person, telehealth, and telephonic. And I will tell you, my bias all along has been that telehealth visits are not the same as telephonic visits, that the actual integrity of the medical visit when you're doing a telehealth visit is higher. And while a lot of payers were paying full parity for telephonic care, North Carolina did not do that. As a matter of fact, even under duress, we only went up to 80% of parity for telephonic versus telehealth because we really wanted our providers to lean into telehealth and use that service. And so the data is now supporting what was our gestalt or feeling around telephonic versus telehealth, and that patients that had telephonic visits were actually more likely to have a hospitalization compared with those that use telehealth. Of course, this is early data, early findings, and we'll see over time when we get more services in whether that holds up. The other thing we looked at was the total cost of care and the impact of total cost of care as a function of in-person telehealth and telephonic. And we again see a trend that's interesting, particularly in the ABD population, so that's our sicker population, that those that had telephonic care had overall higher cost of care than those that had telehealth or in-person care. So one of the things that we have really wrestled with is we went from having one telehealth policy to having 34 that we wanted to keep on because we felt like they really strengthened our Medicaid program and made it a better program for our beneficiaries. And we did that based on some assumptions. Well, now the data is coming in and we're able to study it and see how it was used. And so when we're thinking about the less traditional use of telehealth services, like with our specialized therapies, looking at the data and the utilization patterns is really helpful. So we're challenging some of our assumptions about what should stay on and what should turn off based on how it was utilized.
Thank you, everyone, for joining. And thanks again so very much to our panelists. What a great way to learn more about the future of value-based care and the innovations that are making this idea a reality. I also particularly enjoyed Dr. Dowler's presentation on how North Carolina Medicaid was able to stand up a full, robust telemedicine program and all that it entails in just a few short weeks earlier this year. This truly goes to show how quickly we can make change in healthcare when the acute need exists and we have the will to meet that need.